Thank you for joining us today to further explore opportunities for a partnership between area agencies on aging and the MCO network. Using a case sample, we believe we can help demonstrate how together a partnership can impact quality of life as well as decrease negative medical outcomes and costs. This case study will be around a caregiver and a care receiver. Please meet Mr. and Mrs. Smith. As far back as they can remember, they were connected. They played hide and seek and marbles together as children. When he played high school football, she cheered him on, sitting in the bleachers wearing his letterman's coat. After they married, she worked in the five and dime and he worked as a master plumber. They raised their two children who graduated from high school and promptly moved away to pursue their own dreams and ambitions. Mr. and Mrs. Smith promised they would always take care of each other. Mrs. Smith started to notice that her sweetheart struggled telling their shared stories, and she started filling in more of the gaps. His personality changed too. He was quicker to anger and easy to tear. They were both experiencing little losses. They went from being regular walkers to needing to use walkers in a home not built to accommodate this. Mrs. Smith was not comfortable leaving Mr. alone, as he was starting to wander and was more confused. Mrs. Smith experienced increased anxiety and depression as she managed her husband's changes and the impact this had on their relationship. She began to experience more issues controlling her own blood pressure and diabetes. She was spending increased time caring for her husband and had less energy and time to focus on her own health and wellness. They were devastated when they received a diagnosis of Alzheimer's disease. She didn't speak to her children about their father's losses. Still, they noticed. Mrs. Smith became angry and felt betrayed when the children thought best to place Dad in a residential facility. She refused. Mrs. Smith soldiered on, as she is a wife who loves her husband and is married in good times and in bad, in sickness and in health, as their marriage vows go. She continues to have more difficulty taking care of her husband's needs as well as her own. There were missed visits at primary care, and Mrs. was having more trouble getting Mr. to agree to following the established treatment plan of antibiotics for infection. This resulted in more ER visits. There was a misunderstanding about changes to Mr.'s med routine as a result of a med change at the hospital, which resulted in yet another ER visit. And there was a fall that resulted in placement at a local residential facility for 3 months. Mrs. never missed a day of visiting him, and each time he would say, "Honey, take me home." And she would smile and say, "Soon as you're stronger." As the discharge team at the skilled nursing facility started to work with Mrs. regarding discharge, medical follow-up and plans were put into place. The discharge planner also was aware of their contract with the Area Agency on Aging, and she set up Mrs. to discuss her situation with the Area Agency on Aging team as part of their contract through a referral. Together, Area Agency on Aging staff and Mrs. set about identifying what was important to Mr. and Mrs., what was available as resources, and those things were put into place that Mrs. and Mr. agreed to as part of their in-home care plan. Through this referral to the Area Agency on Aging, Mr. and Mrs. received care transition support, which included med reconciliation and help for Mrs. to better understand red flags and the importance of getting into primary care provider more quickly. She also received much-needed respite, but later decided she would rather have the housekeeping and errand program, as she didn't trust the care provider enough to leave him alone in the home with them. Mrs. Smith received a Star C referral with a coach who helped her better understand her own behaviors that escalated her husband's agitation. This really helped. Mr. also received a robo-pet, a little robotic cat that responds to Mr. with soft purrs and would even roll over for a tummy rub. This seemed to calm his anxiety and reduce his agitation. This addition did not require Mrs. add litter box duty to her day, nor were there fall risks, as this furry friend did not move about the home getting tangled in anyone's feet. In addition, there was a home safety check and home modifications, as well as DME to mitigate falls. Mrs. Smith found this suite of services, which changed over time as their needs changed, really helped reduce her own anxiety and stress. Her own health stabilized, and she was able to keep Mr. Smith at home with fewer hospitalizations until he passed away. Mrs. Smith would say it was an honor to have lived their entire life together, and her most fulfilling moments were when she supported and cared for him during their hardest days, and that they always kept their promise to one another up until the end. As we review this case scenario, we can look at potentials to engage in healthier outcomes and opportunities to decrease costs. So much of both of our systems' time is spent on 5% of our caseload, that group of individuals who are high cost in the medical system, or those who are in crisis and the intervention is often more costly and not what the individual may have wanted for themselves. Earlier intervention is an opportunity to have positive impact upstream. What does this look like in the scenario I just gave? Mrs. started attending appointments with Mr. Identifying her as a caregiver and having a handoff to the Area Agency on Aging to address social determinants of health early can have impact down the road as his care needs change. Missing appointments and lack of skills to navigate his changing behaviors may have resulted in some of the issues regarding infection and increased medical needs. Star C coach or another educational support may have helped. Unmanaged medical needs, coupled with Mrs. own stress and lack of knowledge as to what to do next, may have resulted in ER visits that could have been prevented with additional supports in the home. The number one reason for rehospitalizations is med management. As Mrs. stress increased, her ability to manage new information may have decreased. Providing her support, such as care transitions in her own home with his meds and their process in front of them, may have been beneficial. Multiple issues have built up, leading to a serious injury. DME, caregiver services, and prescription medication transition all may have helped prevent more costly outcomes. Earlier identification and intervention provides opportunity for better outcomes for patients, their caregivers, and the medical network. In review, if we share the vision that there is value in working with medical providers on how to identify family caregivers and what to look for, and we provide an opportunity through referral for earlier intervention, together we can help mitigate the need for crisis management and higher cost. This will also result in a higher quality of life for care receivers and caregivers and support their ability to remain at home. Using this case study, this diagram shows the relationship and how we could work together for increased quality in our service delivery systems. Through a relationship between MCOs, their network providers, and area agencies on aging, Mr. and Mrs. Smith have a greater opportunity to remain in their own home together, fulfilling their promise to be there for each other with better health outcomes and decreased medical costs. Thank you for the opportunity to share this vision with you. Dana will now share with you a little more in depth about caregiver identification.